Hi, everybody. Today we're going to be talking about obesity in Canadian children living in poverty. So, for a quick little introduction, children living in poverty face much more than just material deprivation. And so, this project will focus on just defining the link between poverty and obesity, specifically looking at obesity of anything above the 85th percentile. So, in Canada, 1.1 million children are currently facing poverty right at this moment, and children living in a insecure food household are 2 times more likely to experience obesity. But on a more positive note, the CBC has reduced child poverty by almost 9% annually. And so why did we decide to pick this topic? Well, first of all, it's a cycle of inequity, meaning they both reinforce each other. Moreover, it is a system level impact, meaning individual approaches will not be enough for this case. Lastly, it's an equity dimension issue, which means that marginalized communities are disproportionately faced than others. Lastly, like mentioned, children living in poverty face many challenges such as physical, like poor diet, food insecurity, reduced physical activity, and mental, such as impact on brain structure development and academic capabilities. Lastly, for their social challenges that they face barriers to access to education, job securities, and extracurriculars. And this is why it is so important that we have programs that face each and every individual.
So we explored a few sources to find our evidence. We can see we looked at sources like PubMed, National Library of Medicine, Campaign 2000, StatsCan, and different organization websites. And for our strategies, we put different combinations of terms together periodically as we went through. So we can see them here, like poverty, Canada, children, youth, food insecurity, nutrition, diet, obesity, obese, overweight. And overall, after looking through the articles, we ended up picking systematic reviews, primary literature, and grid literature to find more of the interventions and the statistics. Oh, all right. So for our first results about what is actually in place to prevent poverty, we see that there's some targeting education. So we'll focus on one we found called Head Start. And this is a preschool program from children of low-income families that's aimed to improve their cognitive development. And so longitudinal evaluation of this program actually found that participation resulted in improvements in enrollment and completion of university degrees. And we also see they had better economic self-sufficiency. We see for employment, we have the jobs program we found. Now, this was a randomized controlled trial, and it's basically group training or integration programs that focus on acquiring skills for jobs and for employment. And it actually showed that these work integration programs, as we can see at 6 months and 12 months, led to higher employment retention compared to the control group. Now, for our interventions to support our population and prevent obesity for children living in poverty, we have healthy nutrition assistance programs in schools. So on the left, we have the Healthy Hungry Hunger Free Kids Act, and we have the National School Food Program. Now, these are both very key opportunities for intervention. So school meal programs are very high yield places to put your interventions. And so both of these tried to increase access to nutritious foods and healthy eating habits and improve child health and decrease obesity. And that's exactly what both of these did. They decreased obesity and BMI rates. We can also see that we had physical activity intervention, so daily physical education, recess program for children coming from poverty backgrounds. And these both decreased BMI and decreased obesity as well. And we have a Jumpstart program in Canada, which is funded by Canadian Tire, and it funds participation for children in low-income families in sports. Finally, we also found health education. So these educated children about healthy, balanced meals to prevent reliance on like unhealthy, calorie-dense foods. So we had like diet change lessons, healthy eating lessons, and these actually decreased BMI and percent fat mass and improved their dietary intake.
Of the numerous articles we found, we decided to focus this presentation on 8 more notable studies described previously by Kaylee. The main takeaway was that the best programs were programs that combined both nutrition and exercise, as well as putting a big focus on changing the environment of the child to deal both with the obesity and the poverty. Of these articles, there are many strengths of the studies. We had different study types, including RCTs, which are the best study types, cohort studies, which have large sample size, systematic reviews, one had 47 studies and the other 86, and longitudinal measurements. There were also many powerful policy impacts from some of these studies, including the Head Start study and the Healthy Hunger Free Kids Act studies. There's also some limitations that are necessary to point out. We had observational and cross-sectional studies, which are a bit less robust. Some of the evidence also used self-reported measurements for dietary intake and physical activity levels, which can lead to recall bias and social desirability bias. Loss of follow-up is also an important limitation, as it can lead to selection bias when the comparison groups are not the same. This is often the case in studies related to obesity, as they're more likely to drop out of the study. Unmeasured confounding is also a concern, with some studies not controlling for SES or screen time. Generalizability was also a concern. It was important for us to think about Quebec's context when evaluating these programs. Some of the contextual considerations that we thought about include urban or rural nature of the community where we want to implement these programs. Being in Quebec, we have to consider making our programs accessible in both French and English. We have to think about cultural food preferences and restrictions. We want to make these programs not only accessible, but useful for Indigenous populations. And we want to make sure we're not promoting weight stigma, which is important considering the sensitive age that these programs are targeted at. Lastly, when we think about ethical considerations, we want to make sure that we are targeting disadvantaged populations and not just implementing a one-size-fits-all approach. We want to include parents in the program building, and we want to create programs that are sustainable and can survive on their own.
So for our first success story, it's about the Apple Schools Project, which stands for Alberta Project Promoting Active Living and Healthy Eating. So each school hired a health facilitator who helped integrate healthy meals, nutrition activities, and opportunities for physical activity. So between 2008 and 2010, students in the Apple schools were already eating more fruits and vegetables, consuming fewer calories, and being more active. As for the obesity rate, it declined by almost 2%, while across the province, it actually increased. For our second success stories, it's about the Market Greens, led by the Community Food Centers of Canada. So families with young children living in poverty received about $10 to $20 weekly of produce vouchers for 5 months. So about 300 families participated, and the results were clear. So children ate about 2 more servings of fruits and vegetables each day. Families felt more control over their food choices, and nearly everyone reported better access to healthy food. So our recommendations and next steps based on these 3 examples focus on, first, to fund school-based programs actually with trained facilitators and strong food standards. As for the second one, it would be to introduce food prescriptions so doctors can prescribe produce covered by government funding. And the third one would be to expand nutrition assistance by partnering with grocery stores and community groups to provide vouchers and support. So we feel that by working together with schools and healthcare, governments, and the community, we can make healthy food and habits truly accessible. So for the expected impacts, it would be that children build healthier habits through school and at home also, that families will see greater access to affordable, nutritious food, which would lead to better diet overall. So we can also expect a reduction in childhood obesity and progress towards closing the health gaps linked to poverty. So in conclusion, poverty affects over 1 million children and it fuels obesity-related disease, but prevention through economic support, education, exercise, and nutrition can break this cycle. Thank you for listening.